for adult and pediatrician. But the only thing which we don't see is ischemic heart disease or the typical myocardial infarction, which is commonly encountered in adults. Very rare cases of myocardial infarction are seen in children as a result of significant coronary dilatation caused by Kawasaki disease, and that's the only scenario when pediatric cardiologists get to see ECG changes of myocardial infarction. Or one other issue is where we get ALCAPA, the anomalous left coronary artery from pulmonary artery, where we get to see changes of ischemia on the ECG. Otherwise, the field of work largely overlaps with adult cardiologists, wherein the pediatricians have an upper hand, pediatric cardiologists have an upper hand in congenital heart diseases, and the adult cardiologists are much better off in ischemic heart disease. So this is a brief introduction. I always do this before we start off any seminar, so that the pediatric residents are kind of oriented towards in knowing what pediatric cardiologists actually do. For the last 10 years, there has been DM in pediatric cardiology. In the last 5 years, there is a DNB in pediatric cardiology. So it's become a proper subspecialty right now. So that's where we are. So thank you for this a brief 5-minute time for the introduction, and we'll jump straight away to approach to tachyarrhythmias. So how do we approach a tachyarrhythmia? We see an ECG with very fast heart rate. So what would be our first response? Scratching our head, knowing what it is. This is where PALS guidelines come in, and has helped us a great deal. Even we depend on that. It's kind of really succinct in its approach. It's very simple. So there are two things. You see a fast heart rate. Look at the QRS duration is the first thing, whether QRS is normal, which is less than 80 milliseconds, or QRS is wide, which is more than 90 milliseconds. So this is what we are talking about, a narrow complex QRS or a wide complex QRS tachycardia. So narrow complex tachycardia or wide complex tachycardia. Most likely, I mean, again, most likely, if it is a narrow complex tachycardia, it is likely to be a supraventricular tachycardia. Again, we need to rule out whether it is sinus tachycardia or not. Sinus tachycardia means every QRS is preceded by a P wave. The P wave axis is normal, and the PR interval is normal. And usual heart rate will be less than 220, because the sinus node, if you remember the previous slide where Dr. Maniram had clearly explained about the pathways of the conduction pathway of the heart, if I may just. Okay, the conduction pathway of the heart involves from the SA node by the intra-atrial pathways into the AV node, and from the AV node into the bundle office, into the right and left bundle branches, and then into the Purkinje fibers. I think this basic pathway is mandatory, and all of us need to remember this one pathway consistently for the next couple of hours, probably for our lives, definitely. But at least for the understanding of the approach to ECGs, please remember this basic pathway, so that things become easier for us. So as he said in the previous discussion, how do we say it is sinus or not, sinus rhythm or no? So before every QRS, there is a P wave. The PR interval is constant, and the P wave is upright in 2, 3, and AVF. In the limb leads of 2, 3, and AVF, the P wave needs to be like a hill, upright. So these are the major basic criteria for defining sinus rhythm. So if the heart rate is close to 200 and fits in all the criteria of the P wave being normal, and P wave is preceding every QRS complex, then we call it a sinus tachycardia. It could be any cause, probably fever or any hypovolemia or any other cause for that matter. So we'll just everything is given in PALS guidelines. You just need to read it thoroughly and get over. Now, if that is not the case, then we are probably looking at a supraventricular tachycardia. If it is a supraventricular tachycardia, what next? Usually heart rate is more than 220 and children is more than 180. Now, if we come to wide QRS complex tachycardia, which is more than 90 milliseconds, how do you say it is wide QRS? It can be either two possibilities. It can be ventricular tachycardia. If it is ventricular tachycardia, then it is more ominous. Or A supraventricular tachycardia with aberrancy. The meaning of the word aberrancy means there is a bundle branch block. There are two bundle branches in the circuit of the heart, which is the right bundle branch and the left bundle branch. Blocking any one because of any cause is termed as aberrancy. So a supraventricular tachycardia with one bundle branch block, be it excuse me, right bundle branch block or the left bundle branch block, can cause white complex tachycardia and needs to be addressed as such. So whether it is narrow or white complex, the giving adenosine is a must. If it is narrow complex and or if it is white complex with supraventricular tachycardia as the possible cause, then giving adenosine is the first step. Dr. Maniram will be discussing in detail as to what is the necessary steps before adenosine, giving adenosine, and I'm not going to deal with that in this slide. So this presentation will mainly go over about how well we can understand narrow complex and wide complex tachycardias. So two questions: is the QRS narrow or wide? So there are one more thing: is the tachycardia regular or irregular? If the answer to your question is narrow or wide, if it is narrow, it can be sinus or SVT. Or if it is wide, it can be SVT with aberrancy or ventricular tachycardia. If it is SVT, it can be AV node dependent tachycardia or AV node independent tachycardia. Now, what does this statement mean? So, for the tachycardia to happen in a narrow complex tachycardia or supraventricular tachycardia, you need a extra wire. I would say a wire, which is because it acts, one of these will act as a wire to take current, causing short circuit in the otherwise normal ECG pathway. So when there is a short circuit, it can be because of an additional pathway, which all of us know very well, which is the WPW syndrome. Or if there is no additional pathway elsewhere in the heart, but the additional pathway is within, the enemy lies within, is where the AV node. The AV node, assume it to be like an egg sliced in half. So one half of the egg will conduct current from the SA node downwards, and another half of the AV node may conduct current from the ventricle to the atria. Normally, the conduction should not happen the other way, from the ventricle to the atria. That is why AV node is there. AV node is there to block the current which comes from the ventricle to the atrium. Now, let me tell you one thing. You can ask why normally current does not go through the heart. The heart, the atria, and the ventricles are electrically insulated. They are insulated by a band of collagen known as the skeleton of the heart. The collagen is a bad conductor of electricity. Electricity cannot pass through collagen, and this is where the muscles of the heart are attached. Every muscle needs some attachment, namely bones, tendons, ligaments, everything. You need attachment of muscles, and heart muscles also need those, and they are collagenous ring in the heart, which is called the skeleton of the heart. The skeleton of the heart prevents current from traveling from the atria to the ventricles and the ventricle to the atria, except through the prescribed pathways, which is namely again from the SA node to the AV node to the bundle of His into the bundle branches and the Purkinje fibers. So the problem with AV dependent SVT is the AV node is the problem. The AV node acts as wherein it should have conducted current only from the atrium to the ventricle is now conducting from the ventricle to the atria. So this is the meaning of AV node dependent SVT. AV node independent SVT is nothing but our WPW syndrome, where there is an accessory pathway or the short circuit or an extra wire which connects the atrium and the ventricle directly. I would be showing all these in the subsequent slides. There are good pictures which are available. So there would be a direct connection from the atrium to the ventricles, bypassing the pathway, the regular pathway, as well as bypassing the collagen ring or the electrical insulation of the heart or the skeleton of the heart. So when that is present, it is called AV node independent type SVT. As I said, SVT with aberrancy means SVT with any right or left bundle branch blocks, or it can be ventricular tachycardia. What are the tachyarrhythmias? So narrow QRS tachyarrhythmias. I'm just going to name the tachycardias right now, what we are going to see in the next few slides. So AVRT, atrioventricular reentrant tachycardia. It's atrioventricular reentrant tachycardia. AVNRT, atrioventricular nodal reentry tachycardia. AVRT is the typical example is WPW, wherein there is an accessory pathway. It is called atrioventricular reentrant tachycardia. AVNRT, atrioventricular nodal reentry tachycardia, where there is a AV node is the culprit, and hence the term, the letter N has been inserted there, and it's called atrioventricular nodal reentrant tachycardia. The reentry. When you mean reentry, the current is passing from the ventricle to the atrium. So that's what is meant by reentry. So in AVRT, the reentry happens by a short circuit wire or the accessory pathway. The subsequent ones are also kind of common, but yes, we do see it commonly. So atrial flutter is nothing but a typical, it's also a type of re-entry tachycardia, but the re-entry happens within the atrium itself, inside the atrium itself. It doesn't come down to the ventricles. So there is atrial flutter. Atrial tachycardia is nothing but there is a place in the atrium which is firing current faster than the sinus node and causing tachycardia. So it's called atrial tachycardia. So there is a SA node which is normally firing, giving impulses at regular intervals of time. But in atrial tachycardia, there is a point in the atrium. It can be anywhere in the right atrium or the left atrium or anywhere in the atrium, which can cause significant discharge of current causing tachycardia. That will be conducted normally through the AV node into the ventricles. So that will cause sinus tachycardia like picture, but it would be faster than a sinus tachycardia. So that is called atrial tachycardia. Atrial fibrillation is usually very uncommon in children less than 12 or even 15 years of age. You need a significant age group, and it's very uncommon in children. So we really don't see that in day-to-day life. But adults, the commonest atrial SVT or tachycardia is seen is atrial fibrillation in adults. PJRT is a rare form of tachycardia seen in neonates and in infants. Permanent junctional recurrent tachycardia, PJRT. Okay, JET is junctional ectopic tachycardia. So JET is commonly seen in children with postoperative conditions, but both PJRT, permanent junctional reciprocating tachycardia, as well as junctional ectopic tachycardia, both are seen in normal hearts, can be seen in young infants, and both are notorious to not respond to any form of treatment, and they take a long time to resolve and needs intensive medical management for the treatment of the same. We'll be dealing with all those shortly. Now, broad QRS tachycardia is ventricular tachycardia, and let us, for the sake of simplicity, just keep ventricular tachycardia into picture and not deal with anything else. How do you differentiate the narrow complex tachycardia? Now we have come this far. The first two questions we asked, whether it's narrow complex or wide complex tachycardia. Is it regular or irregular? So let us assume, let us take one by one. So we now know it is a narrow complex tachycardia, and we see whether it is regular or irregular. Narrow complex tachycardia usually are regular. So let us say it is a regular narrow complex tachycardia. Now the third question you need to ask is, do you see a P wave? Now, if you had asked me this question even when I was starting cardiology or the few months into cardiology, if you see a P wave, it was a very difficult question to answer because everything looks the same in an ECG as a beginner. So I strongly, believe that looking at more ECGs, as he said in the last slide, will help us overcome this fear and then get a good grasp of the ECGs. So looking at the P wave. Now, how do you know it is the P wave or the T wave or the QRS, one of the QRS waves? Now, P wave has specific characteristics. They are never blunt. They usually have a nice peak, but it's not sharp as much as you think. But they have a very gentle peak and then but the T wave is usually very smooth, and it's like a very gentle speed breaker. P waves are little harsher speed breakers. Okay, they are little go up and down pretty quicker. So this is what, how do you identify a P wave? So it can be a P wave or a T wave. So you please look at a P wave. And usually T waves are not seen in SVT because they get buried. The T wave gets buried in the QRS complex anywhere. So next question you need to ask is the P wave closer to the previous or the next R wave? So if the P wave is closer to the next P wave, it is called short RP. If it is closer to the next R wave, it is called the long RP tachycardia. So this is short RP versus long RP tachycardia. This is just to quantify our things, and subsequently in the discussions we would have put elsewhere that why long RP or short RP tachycardia. This is again just to begin with a normal sinus rhythm. So if you can see my cursor here, so this is the atrium, this is the sinus SA node which is there, and all the waves which pass through both the atrium converge at this point, which is the AV node, and then the AV node discharges, consolidates all the current coming from both the atria, consolidates it, and then passes it down through the His bundle into the right bundle branch and to the left bundle branch. So this is the left ventricle, this is the right ventricle. So both the current is passed on from the right and the left bundle branches, and it goes on into the ventricles. So the P wave is the wave current traveling from the SA node to the AV node. That is, atrial contraction is seen as this P wave. The QRS is nothing but the ventricular contraction. When the ventricles relax, you get the T wave. As the ventricles have a significantly more muscle mass than a thin atrium, you get a T wave. Also, the P wave repolarization, that is the atrial repolarization, gets buried within the QRS complex here. So that is the reason we do not see a atrial repolarization wave. So this is normal sinus rhythm. As we said, it's called ventricular pre-excitation. AVRT, atrioventricular reentrant tachycardia, also called as ventricular pre-excitation or WPW for the sake of simplicity. There are multiple causes for ventricular pre-excitation, but the commonest is WPW, Wolff, Parkinson, White syndrome, described way back in the 1930s. So it's a pretty old disease by our standards right now. So why is it called ventricular pre-excitation? This is the sinus node. The sinus node is generating the impulse. It is giving the impulse into the AV node as well as elsewhere into the atrium. Now, if this was not present, I hope you're able to see the cursor. If this is not present, this is an additional pathway which I am showing here. This is the short circuit which I was talking about previously. So the atrium, in the previous slide, we saw that all the current of both the atria are consolidated and comes into the AV node. But here in this situation, what happens? Both the currents of the atrium have an accessory pathway or additional pathway through which it can go. Now, AV node is a very nice regulator. It regulates the current. It takes in the current, makes it wait. The PR interval, it makes it wait and then gives the current to the ventricles. But this accessory pathway is not so forgiving. It is there. It says, I'm there and I'm going to allow the current to pass through. I'm not going to wait like the AV node. So this will allow the current to pass into the ventricles without any delay. So this is what happens when there is an accessory pathway. So the SA node current passes through both AV node as well as through this accessory pathway or the short circuit into the ventricles. Now what happens when this passes through when the ventricles get current through this accessory pathway is what forms the basis of a WPW ECG. Okay. So you can see that here the current is passing through both ways, and then when there is an accessory pathway, that particular ventricle, it can be either the right ventricle or the left ventricle. So here there is in this GIF, it is shown as if the left ventricle has an accessory pathway, but in this static image cartoon, it is shown as the right ventricle has the accessory pathway. So the accessory connection is from the right atrium to the right ventricle. In this GIF, it is from the left atrium to the left ventricle. So what happens? There is no delay. As I said, there is no delay. There is a short PR interval. The PR interval is not well formed. So the P wave followed by a small space will be there in normal. But instead of that, there is a delta wave. Directly the QRS impulse starts, because as we see here, the current instantaneously depolarizes the ventricles. It means the current depolarizes, that is, the ventricles get activated by the current coming from the atrium, wherein normally there should have been a delay because of the AV node. Here the current comes directly to the ventricle without any delay and causes depolarization. But we have to remember one thing, that current passes fastest through the AV node and through the wires which line the heart, namely the His bundle and the bundle branches and the Purkinje fibers. If the current comes through this pathway, it has to reach the muscle, and then the current travels from muscle fiber to muscle fiber instead of the wire. The wires are omnipresent, namely the Purkinje fibers are all omnipresent, but here it is not so. It has to travel from muscle to muscle. So the conduction along this pathway is slower. So there is depolarization, that the ventricles get activated, but it will be slow. By the time this ventricle gets activated, the current from which comes through the AV node here and here reaches both the ventricles. And because there is a delay in conduction when the current comes through this accessory pathway, there is a QRS widening, or the delta wave is formed. So there is wide QRS complex along with a short PR interval, because that current comes directly into the ventricle without any delay. A short PR with a delta wave causing widening of QRS complex is the hallmark of a ventricular pre-excitation, or the WPW pathway. I hope I have made myself clear in this slide, the previous slide, because it's very important. It's a common question in both MD exam as well as in the OSCE for DNB pediatric postgraduates. So now what happens in SVT? Okay, so the current comes down, and what happens is it doesn't, it just doesn't stay within here. The AV node normally is, as I said earlier, is a one-way path. Current has to come from the SA node to the AV node and down. But as I said, this accessory pathway doesn't have all those rules. They don't follow any rules. The current can come through this, and current can go through this, go back, rise up to the atrium. Now what happens when the current comes? Previously, when you see here, when the current is coming here, you can ask why it is not going up here. It goes up every single time through this, but it will not find this atrium in a phase where it will accept that current. Namely, it is in the refractory period. Now, when the atrium is refractory, whatever current comes, the atrium will not contract. But what happens here? When the atrium is in the relative refractory, there are two types of refractory period: absolute refractory and relative refractory. In the relative refractory period, if there is a stronger impulse, it is possible to the atrium to contract at a little lower force of contraction, but yes, it can contract. So when that impulse catches it during that phase, it sets off a cycle. It's called the circus movement re-entry. It just keeps running around like this in circles. So that sets off a trigger and causes SVT because of accessory pathway. So normally when the atrium is in absolute refractory period, the current will not be taken up by this. But when there is in the relative refractory period and this impulse is strong enough to make the atrium contract at a lower rate, still that is sufficient to set off this AV node, because AV node is ready and then it will send it down again. So when this starts off as a circus movement re-entry is what we usually described right from the pharmacology days. So this happens and SVT occurs. This is the ECG of a typical SVT. Now, atrial flutter, as I said, is another form of re-entrant tachycardia. The re-entry happens within the atria itself. It doesn't go from down and up. So the atrium, the re-entry happens here. So it discharges the current in a much higher rate than the AV or than the SA node, and hence causes SVT. So the discharge may be anywhere between 300 to 350, but whatever is conducted will be probably 180 to 190. So this is atrial flutter. It's another form of SVT, and it's commonly sometimes seen in newborns and commonly seen in post-operated children with heart disease. I do have a better image of atrial flutter, yes, but this is what we see. Get the sawtooth pattern. There are multiple P waves happening. So there are multiple P waves before every QRS. So when there is multiple P waves, it appears like a sawtooth. So that is the reason for atrial flutter having sawtooth-like pattern. Atrial tachycardia. As I said earlier, atrial tachycardia is a focus anywhere in one of the atria, by the right atrium or the left atrium, and is giving out impulse at a rate faster than the SA node. The SA node is here, and this is the focus or the abnormal area of the atrium, which is discharging current at a rate faster than the sinus node. What happens in this here? There will be P waves everywhere, but the P wave axis will be abnormal, because as Dr. Maniram previously said, the P wave axis need to be in this direction from here to here. It has to be in the right lower quadrant. Okay, it has to be in that quadrant, the P wave axis. Now, because this P wave is traveling in the direction opposite to that, you will not get the P wave axis normal. So it will not be upright in 2, 3 and AVF. You will get tachycardia, you will have a P wave on ECG, but the P wave axis will be abnormal. It will not be positive in 2, 3 and AVF. And that is the reason we call it as atrial tachycardia and not as sinus tachycardia. So in this is again a picture of the normal heart conduction system of the heart. If there is an abnormal, if there is an abnormal axis, like I said yesterday in the previous slide, so the abnormal impulse, instead of the normal impulse should come from here to here, it should fall somewhere here. If the impulse is abnormal, it can be in any other axis. So the P wave abnormality is what we are talking about for atrial tachycardia. As you can see here, the P wave is negative in AVF. So if it is negative in 2, 3 AVF or all three, either 1 or 2 or 3, all three, then it is an abnormal P wave. So we have to look at the axis of P wave into leads 2, lead 3 and lead AVF. So here, as you can see, it is negative in the lead AVF, but it still looks like a sinus rhythm. But the heart rate is not really like sinus rhythm. It's more than 225, the heart rate is here. So it is most likely a SVT. Possibly it's a atrial tachycardia. I hope I'm clear and I'm not confusing everybody with all our jargon. I really wish it was, as he said earlier, it was a live class so that we could address it more effectively. But during this pandemic times, I think even this form of learning is kind of interesting as of now. So let's just get on with it. Okay. So this GIF is, we didn't get a GIF of the atrial fibrillation, but so this is something like ventricular fibrillation. So the same thing happens here. The multiple focus sitting in the atrium, instead of the ventricles, you assume this focus are sitting in the atrium and just keeps, the atrium keeps trembling and then giving out impulses at random intervals. So there is a irregular pulse. That is the hallmark of hallmark clinical finding of atrial fibrillation. Now, atrial fibrillation, as I said, is very uncommon in children, and with rheumatic heart disease being on the decline, we do not generally see that many atrial fibrillation patients. And usually, if you have to see atrial fibrillation, you need to have at least a 12 or 15-year-old child with who's well grown and has probably rheumatic heart disease, having mitral stenosis. So there are so many factors which come into play here and to cause atrial fibrillation, which we see here. But yes, we do see atrial fibrillation in post-operated patients too. But as cardiologists, that becomes a very common thing for us, but not for the pediatricians per se. So this is atrial fibrillation. Last but not the least, the VTAC here. So VTAC, we'll keep getting abnormal pathway, which keeps giving uh, causing its own rhythm from the ventricles. Now, as I said, if the rhythm originates from the ventricle and causes contraction, it is going to be wide, because the muscle to muscle conduction of current is slower, and hence the conduction will be slower and cause a wide QRS tachycardia. But the same thing cannot be said if there is a supraventricular tachycardia, because the conduction happens through the AV node only. But that doesn't happen here. It happens through the ventricle, and the conduction happens from muscle to muscle, and hence the reason for wide complex tachycardia. The hallmark of a QRS tachycardia, I mean ventricular tachycardia, is these three: AV dissociation, capture beat, or fusion beat. AV dissociation, there is no relation between P wave and QRS complex. So the P wave comes, QRS complex occurs. The P wave, QRS. There is no steady relationship between P and QRS. The PR interval needs to be regular for it to be termed as a sinus tachycardia, but that is not so. Here the PR interval is not regular. The P wave keeps coming and just marches on along the QRS complex, and hence there is AV dissociation. A capture beat. Once in a while, what happens in this scenario, as you can see from here, there is the SA node will keep functioning. But once in a while, it so happens that this ventricle is resting or keeping quiet, and the SA node will impulse will capture the ventricles, and hence this happens. Capture beat. There'll be a P wave followed by a QRS. See, look at this, is narrow and looks like a normal QRS complex. This is called a capture beat. So this is a AV dissociation, and this is capture beat. This is a normal sinus beat. So we'll have to look for a normal capture beat at any given point in time. A fusion beat, when both together occurs, is what you call it as a fusion beat together here. It can be narrow, and it is probably a little lower down, and hence it looks narrow. These are all wide tachycardia, but this looks a little narrow. So it is fusion beats. So AV dissociation, capture beat, and fusion beats are the hallmarks of ventricular tachycardia. Now let's go into a few clinical scenarios for now, and then we'll see how best we have understood the whole thing. 16-year-old boy with recurrent episodes of palpitation, commonly precipitated while playing, short lasting, settle spontaneously, no loss of consciousness or other symptoms. Was referred for evaluation. It's a common symptom which even today, which parents bring their child for the same thing. So I hope after the prolonged discussion on WPW syndrome, you're able to appreciate this ECG. If you remember Dr. Maniram's PowerPoint slides, you would still appreciate how nicely he has put it through. First, look at all the P waves everywhere. They look okay. How about the PR interval here? The PR interval is extremely short. It is, for a PR interval, you need to have a P wave and a small dash, which is the PR interval. But here there is no interval. After the P wave, the QRS starts instantaneously, and this is evident in this particular tracing here. After the P wave, the QRS starts immediately. And yes, you can see the delta wave also very clearly. And there is QRS widening. So no PR interval, QRS appears wide, and there is delta wave. All three gives us a diagnosis of WPW syndrome. Newborn baby with uneven filled perinatal period, admitted because of maternal GDM. A very common scenario. Noticed to have high heart rate on day 3 of life and continues to feed well. Very stable child. How would you go about it? This heart rate, does it look very high? At first glance, it doesn't. The most important things are whether standardization becomes really mandatory, and hence you'll have, whether even though it is showing as high heart rate, the heart rate as per the ECG is close to 160 per minute. So we would be like, why? Most preterms or even any term infant who is little active can have heart rate of 160. What's wrong? So that's where standardization comes into picture. As we said earlier, standardization has to be 2 boxes here, which is 10 millimeters and a speed of 25 millimeters per second. but here the speed is 50 millimeters per second. So it is doubled. So naturally the heart rate here is close to 300 per minute. So this is the actual ECG. So it's not so common scenario, but yes, do we have? So if by going by the questions which we earlier discussed, is a narrow QRS tachycardia or a wide QRS? So it's obvious that is a narrow QRS tachycardia. Is it regular or irregular? It is regular. Can we see the P wave in this? So you can ask which lead to see the P wave in. You can see for the P wave in any one of the limb leads, either 1, 2, 3, AVR, AVL, AVF, or in lead V1. So do we see the P waves here? Yes, we do see the P wave. I hope my cursor is visible to all of you here. So the P wave is visible here. So this is the P wave here. They're in all directions, shapes, and sizes. It's closer to this QRS than this QRS complex. So it's a short RP tachycardia. Commonest tachyarrhythmia in infancy and in childhood is SVT, regular narrow complex tachycardia. We have not seen usually, but fortunately we could see. Terminates with adenosine, commonly not associated with structural heart disease, as would be the scenario. For most of you would have realized this by now, because the echo would be bang normal, but the child would continue to have SVT in and out. So when in doubt, what do you do? 11-year-old boy with CHD, admitted with acute onset palpitation, stable, heart rate around 140 to 150, no arrhythmia. Again, is it a narrow or a wide complex? So it is narrow complex tachycardia. Is it regular or irregular? It is regular. So can you see the P waves here? It's very well. We can see the P waves here. There are not one, at times there are two P waves here. If you see, there are two P waves, 1 and 2. So, but they are not in the same direction. We expect the P wave to be upright in AVF, but it's not upright, it's down. So if you really slow this down, look at this, there are two P waves. And if you really slow this down, if you slow this ECG down, you can make out whether there is a P wave or not. How do you slow down the heart rate? So that is where we get adenosine into picture, which will be dealt with in detail in the next, because we feel that adenosine is an important part of every pediatrician's armamentarium, and it should be in place in the ER, just like we have ADRI and NOR-ADRI in every pediatric emergency room. The same photo, basically. Now here we have administered adenosine, and as you can all see here, this is a QRS, this is a QRS, and in between the QRS there are multiple P waves. It's nothing but a sawtooth pattern, a hacksaw, just like that, a sawtooth pattern, which is clearly indicative of atrial flutter. So clues for flutter: any acute deterioration in adolescent or adult with CHD, heart rate around 150, sawtooth appearance. Any irregularity will offer clues. When in doubt, use adenosine. Treatment will be DC cardioversion, synchronized cardioversion. There you can see here shock. You synchronize the cardioversion to the P waves and then deliver the shock here, and the child gets back into sinus rhythm instantaneously. A small amount of shock is more than sufficient to revert the atrial flutter to sinus rhythm. Again, transient tachycardia noted during an obstetric scan at 37 weeks, delivered by emergency LSCS. No perinatal concerns, no hemodynamic instability. So, persistent tachycardia. So as you can see, the P waves are negative in probably, we don't even know which leads we are looking at. So, but we do see P wave. It's narrow complex tachycardia. It is pretty regular. It is regular. So regular narrow complex tachycardia, where you can see the P waves. Yes, you can see the P waves. Now, if you ask me whether it is a short RP or a long RP, it is long RP. So the P wave is occurring closer to the subsequent QRS than this QRS. So the previous slide we saw was a short RP tachycardia. Here you can see a long RP tachycardia. As I said, this is PJRT, permanent junctional reciprocating tachycardia. So it's one of the commonest tachycardias to be seen in childhood, in early childhood, neonates and early childhood. Unfortunately, it's really difficult to control this tachycardia, needs multiple antiarrhythmic drugs for treatment. So as we saw earlier, the negative P wave in 2-3 AVF, long RP, frequently leads to ventricular dysfunction. There's something called tachycardiomyopathy. That is the reason we are kind of worried. We do not leave a child in tachycardia. You may ask what happens if we don't treat an arrhythmia. This is what will happen. Now, tachycardiomyopathy is the ventricles become tired because they are constantly beating at that fast heart rates. And subsequently, they'll say, no, we don't want to. And they'll start dilating. The muscles of the ventricle will start dilating, and the appearance will be like that of a dilated cardiomyopathy. So when you have a dilated ventricle, it's not good news. When that happens, the child will go into shock, and probably you're looking at a very bleak outcome when such things happen. So treatment of arrhythmia is mandatory. If you have allowed the child to go into tachycardiomyopathy, it means that the arrhythmia has been missed for quite some time. So this is the reversion of sinus rhythm from a tachycardia. As you can see here, there is a negative P wave here, but once you treat the arrhythmia, you can see the P wave becomes upright. So this is upright P wave, QRS, upright P wave, QRS. So this is return to sinus rhythm from tachycardia. 7-year-old boy, previous well, acute palpitation, said to be normal. So what do you think this is? Again, it's a narrow complex tachycardia. Can you see the P wave here? Yes, I guess so. I can see it from my screen here. I hope all of you can appreciate the P wave. It is a short RP tachycardia. So why do you think it is short RP tachycardia? It is short here, and the P wave is not normal axis. The P wave is negative in 1, in 2, probably positive here, but not very positive here. It's kind of negative, as you can see here. It's closer to here. So negative P wave in 2-3 AVF will cause atrial tachycardia and incessant tachycardia. Older child, P wave is seen, give adenosine. This happens always on Sunday afternoons when a boy with asthma, sudden onset palpitation, no hemodynamic instability, no LOC or giddiness, no family history of sudden cardiac death. So what do we call this? Is it a wide complex or a narrow complex tachycardia? It's a wide complex tachycardia. Though I cannot call it, fairly regular or irregular. We don't know. But as if we look at this one lead, you can see AV dissociation. The P wave is seen here. The P wave is not seen somewhere. Suddenly P wave is appearing out of the blue somewhere here. And in between, you can see a capture beat, AV dissociation, maybe a fusion beat. So capture beat, AV dissociation, fusion beat, sometimes you can see, not in this frame maybe. So this is nothing but a ventricular tachycardia. So this is what is a ventricular tachycardia usually looks like. So treatment is definitely yes, based on PALS guidelines, we go ahead and do it. If the child is unstable, we have to cardiovert the child. If the child is stable, then we wait and then medicate the child and go ahead about this. Okay, so this is what we were discussing right now. So ventricular tachycardia clues, AV dissociation, capture and fusion beats, and wide complex tachycardia. So that would be the end as of now, but not completely. I hope I have done some justice to the topic given to me as of now. I hope most of you have understood what we were trying to convey. If not, we'll always happy to help, and we are here. So